Welcome to the McTox Curriculum, brought to you in collaboration with Western University, the University of British Columbia, and McMaster University. This presentation is part of the McTox Curriculum, which has been created for residents and fellows from PGY 1 to 5. Today's topic is going to be about anti-dysrhythmic toxicity. By the end of this video, learners should be able to understand the classification of different anti-dysrhythmic drugs, discuss the basic concepts of cardiac toxicity, and to develop an approach to the treatment of anti-dysrhythmic drug poisoning. Shown here is a simplified schematic picture of the cardiac action potential. First, let's focus on the initial depolarization area. This is where drugs that block the fast sodium channels can slow down the cell's depolarization. At the other end of the action potential, drugs that block potassium channels can prolong cellular repolarization. Both of these effects will result in a prolonged cycle of the action potential, and this fact can predispose cardiac muscles to dysrhythmias. Generally, anti-dysrhythmic drugs are categorized into 4 groups based on the von Willems classification. Class 1 is your sodium channel blockers, 2 are beta blockers, 3 are potassium channel blockers, and 4 are your calcium channel blockers. Starting with the first class. As mentioned before, Class 1 anti-dysrhythmic drugs block sodium channels, and as a result, all of the Class 1 drugs slow down the depolarization phase. Therefore, Class 1. Further subclassification divides these drugs into 3 categories, A, B, and C, based on their effect on the repolarization phase. Class 1A and 1C also have potassium blocking properties and can prolong repolarization and the action potential in general. These lead to a prolonged QT even in therapeutic doses. On the other hand, Class 1B drugs shorten the repolarization phase. Since they only affect ischemic cardiac cells, have a rapid on-off effect, and don't block potassium channels, in general, the Class 1B drugs don't prolong the QRS in therapeutic doses, nor do they affect the QT interval. However, the bottom line is that any overdose of a Class 1 anti-dysrhythmic will suppress cardiac contractility, interrupt conduction, and affect automaticity. Moving on to the other classes. Class 2 are beta blockers and Class 4 are calcium channel blockers, and both are going to be discussed in the basic antidotes module and therefore will not be reviewed here. Class 3 agents block potassium channels and prolong both the action potential and the refractory period. They are also called antifibrillatory drugs. If you remember, Class 3, like Class 1A and 1C, they all have potassium channel blocking properties and can cause prolonged QT even in therapeutic doses. Clinically, QT prolongation is important because it may lead to torsade de pointe. Most of the anti-dysrhythmics that we use have a very narrow therapeutic index. Here's a list of some of the common examples of the different anti-dysrhythmic drugs you may see. Time for a case. You have a 36-year-old gentleman who presents with a new onset of atrial fibrillation that began about 6 hours ago. He denies having any chest pain or shortness of breath or any palpitations, and he has no past medical history and does not take medications. His vital signs are normal except for a heart rate of 138. You correctly diagnose his AFib on ECG. After going over the risks and benefits with this relatively stable patient, you decide to attempt a chemical cardioversion. You give him the standard 1 gram of procainamide over 1 hour, with orders to have continuous cardiac and hemodynamic monitoring. Unfortunately, you are paged overhead to reassess the patient as his blood pressure begins to drop. At the patient's bedside, you find him awake and alert, but feeling mildly dizzy. You check, and it seems that his procainamide infusion was started only 15 minutes ago, except he got 10 grams of procainamide instead of 1. You quickly check his rhythm strip on the monitor and find him in a wide complex tachycardia. You take a moment to recap. So right now you have a young, otherwise healthy male with an iatrogenic intravenous overdose of procainamide at about a 10 times the therapeutic dose. Currently, he is in an unstable, wide complex tachycardia, which is mainly due to the sodium channel blocking effect of the procainamide. His level of consciousness is maintained without any seizure activity. What will be your approach and your next step to manage this patient? Let's go through systematically. The overdose was intravenous, therefore there is no role for decontamination or enhanced elimination. IV fluids are necessary to support low blood pressure and to also increase cardiac contractility. As a sodium blocker overdose, it would seem intuitive to want to give a 3% normal saline solution to overcome the sodium blocking effect and to resume a functioning cardiac action potential. However, sodium bicarb also contains a hypertonic sodium concentration and is actually considered the first choice. Supportive treatment with various inotrope suppressors, such as norepinephrine, is also recommended as needed. If the patient does deteriorate into torsade de pointe, they can be treated with an IV bolus of 2 grams of magnesium sulfate as needed. The questions we'll leave you with for the end of this module are 1. What is the effect of class 1 antidysrhythmic drugs on CNS organs? Question 2. What is the role of electric cardioversion in the case presented? And 3. What class of antidysrhythmic would you choose to treat this patient with if needed? Thanks for watching, everyone.